Hello and welcome to our September 2022 review of the latest lupus literature. I'm Ed Vitale. I'm the chair of the Lupus Forum and I work at the University of Leeds in the United Kingdom. And I'm delighted to be joined today by Professor Vibeke Strand, who is a professor of immunology and rheumatology at Stanford University School of Medicine in California. Welcome, Vibeke.
Thank you. Nice to be here.
So, as you'll know if you follow these podcasts regularly, every month we review the lupus literature to look at the latest papers that have come out, and the steering committee selects some highlights. So today we've got the highlights of our August and September literature searches to discuss. And the first two papers were both related to the theme of damage accrual. So do you want to kick us off and talk about the first of those?
So this paper by Callis et al. Is from Johns Hopkins University, and they're looking at their cohort and the trajectory of damage accrual in lupus based on actually comparing African American with Caucasian Americans. And as we see, unfortunately, it is true that damage, pulmonary, skin, renal, and total damage accrues more and faster in the African American population. And this is unfortunate and not entirely explained by the disparities in socioeconomic status. And what we've learned in the US among our lupus patients is that in general, African American, Asian American, and Hispanic American minority patients tend to do more poorly. And it isn't entirely explained by either access to medical care or socioeconomic status. So we have to fix this, and how we're going to do that is going to be really quite a challenge, because among other things, it's been very difficult for us to get these minority patients enrolled in our trials. And that's something that's quite important.
Yeah, I was very interested in this because I'd looked at some of these similar questions myself with rituximab recently in a paper that maybe we'll be discussing in one of the future podcasts. And for rituximab therapy, what we could see is responses were different, and that had a lot of biological correlates in terms of things like autoantibody repertoire, interferon signature, which was almost always high in the non-European ancestry patients, and many of actually the whole way in which these things related to response seemed to differ. So it kind of suggested to me that you might need more of a range or more of a choice of therapies to really be able to make a difference to this.
I agree. And
I think we've seen that some similar signals, haven't we, in the Bulimumab study, some of the relationships between ethnicity or ancestry and response to therapy was quite complex, wasn't it, depending on both ethnicity and geography.
Yes, it is quite discrepant. And you remember in phase 2, the African Americans did better. Yeah. But there were fewer enrolled into phase 3 studies. So there's a lot for us to learn.
Yeah. So a lot to be done here. It's going to be a challenge. And then this other one, which also relates to damage, to predicting damage accrual, I guess trying to get into understanding what we might need to do to improve the situation. So here they were looking at having low or well-controlled disease activity and damage. So there's a few different definitions that have been proposed, and they looked at several of them: remission off treatment, remission on treatment, low disease activity, LL-DAS, or patients who didn't have any of those and were in active disease. And the essential conclusion is one that I think you predict, which is that being in one of these states of remission or low disease activity, and the longer you're in that state, the better things would be in terms of long-term damage. So I guess that's what you expect. A couple of things that I found a bit interesting. One is that it didn't seem between these different states, some of which are stricter and harder to achieve than others, there didn't seem that big a difference. So, complete remission or low disease activity states that allow a little bit of a score on the SLEDAI or something seem to have broadly quite similar effects. The other things that made me think about, when I thought about it for a while, I was thinking, well, what, when you wonder, the SLEDAI is a useful tool for this kind of research, but there are some things that it doesn't capture very well. So if you have any rash, you'll have 2 points, regardless of the severity, from mild to severe. But you can sometimes have some quite bad hematological disease activity without really scoring too much on the SLEDAI, or you could have patients who have quite a bit of MSK pain, but not really swelling, might not get the arthritis points. And so it just made me think a little bit about which patients were and weren't classified as being in these states.
Yeah.
And whether other tools would have done a better job. I don't think we really know that, do we?
No, I don't think we do. And I think that's one of the issues. We're going to be talking about responder analyses as well. And basically, they're only as good as the disease activity measures we use. And I think using BICLA and SLEDAI, we've learned a lot about what the strengths and the weaknesses are of these 2 disease activity scores. And there's definitely differences between them.
Yeah. And the other thing I thought about this was, just like on the previous study we talked about, I was kind of thinking, okay, what do we need to do to make this situation better? And we don't necessarily know for sure. Does that mean that if I just give more and more therapy to really try and get more people in low disease activity, I'm definitely going to see a difference in damage or how big it is? Or are some of these people just going to do well anyway? And going and being much more aggressive with therapy is not going to completely solve the problem. I don't think we've got those kind of data are quite well established in something like rheumatoid arthritis, but I don't think it's quite as clear here, is it?
No, I agree with you. I don't think it is.
That sounds like a good time to go on to the health-related quality of life study. This is a systematic literature review, this paper, which is so what they did, this group, is they did a systematic review of literature relating to health-related quality of life in studies, and those could be RCTs or real-world or cohort observational studies of patients receiving biologic therapies. So they retrieved all of these data and have summarized it in quite a bit of detail within this paper. And their particular points they were interested in. One is about trying to quantify not just statistical significance, but kind of how meaningful the changes are, I think. So they sort of talk about what's the minimal clinically important difference and how often is that size of effect achieved on the biologic compared to placebo. And then they also go into quite nicely into a discussion on whether, given that there is quite a bit of variability in the quality of the data on health-related quality of life, whether it could be targeted more directly as an outcome on trials and or in the outcome measures. I mean, this is really your expertise, isn't it? So is that a fair summary?
Yeah. So, well, let's look at these conclusions and think about it in another way, because unfortunately, their systematic literature review really missed a paper that came out just about the time they were finishing this. So if we go back, and they reviewed the Bulimumab data, but when it was being presented at the FDA Arthritis Advisory Committee that led to the approval of Bulimumab, the statisticians insisted on looking at the secondary outcomes by SRI-4 responders versus non-responders, regardless of treatment group. And so we did that, and we saw very nice, strong, convincing health-related quality of life data. The SRI-4 responders reported statistically significant improvements and the SF-36 PCS score, and all 8 domains. And these were clinically meaningful improvements. They were greater than or equal to MCID. And similarly, there was statistically significant and clinically meaningful improvements in the FACIT fatigue. So although they didn't have a patient global assessment of disease activity, we could see from the transition question of the SF-36, as well as these data, that responders clearly felt a lot better. Now, if we see the Anaphylaxis data that unfortunately was published after they had done this review, we looked at the BICLA responders across TULIP 1 and 2 versus non-responders, again, regardless of treatment group. Statistically significant improvements in virtually all the patient-reported outcomes: patient global assessment of disease activity, SF-36, PCS, MCS in all 8 domains. The lupus qual as well, all domains were statistically significant, as was FACIT fatigue, as was pain. And finally, that more patients reported improvements that were greater than or equal to MCID in all of these domains. And in fact, even 17 to 49% of the BICLA responders reported improvements that met or exceeded the US age and sex matched normative values, which is something that, in fact, in their conclusions, they had said had not happened. So I'm going to show you the spidergram of the SF-36 data. You can see the domains starting with physical function at 12 o'clock and going around clockwise. And now you're looking at the baseline age and gender match scores versus this outer polygon, which is the US age and gender match normative scores. These are the baseline scores. You can see there's a lot of impact of lupus across all the domains of the SF-36. And here now are the improvements in the non-responders and the improvements in the responders. And you can see these are large improvements. They're all statistically significant, and they start to even approach some of the normative values. And if we look at the next figure, you can see how many of these patients are reporting scores that are clinically meaningful across the PCS, MCS, and all the domains, which is really a very nice level of improvement. And we can see in the next slide that, in fact, many of these patients are now reporting scores that meet or exceed normative values. If you look at the Anaphylaxis group, baseline and then week 52, large improvements. And similarly for the FACIT fatigue. So based on these data, I would agree with their conclusions, except to say that we do know how to look at patient-reported outcomes if we're looking at responders, either by SRI-4 or BICLA. And in fact, these response definitions do yield important improvements to patients. But we should have another step, and that would be to develop responder analyses that included PROs, whether it be one or several. Have I convinced you, Ed?
Yeah, so actually, when you show it like that, you see a really different story, don't you? Because when you just look at the group level data for one arm and the other, you can sometimes think some of these differences are a bit borderline. You know, it's quite obviously quite difficult to show the benefit in health-related quality of life. But here, what you see is what that group level thing is hiding quite a lot of detail. There are a really large number of people who are getting really excellent outcomes that you just don't see it when you look at an average, right?
Yeah, and I think that's important too, because remember that our control group is actually receiving active therapy. And so it's really important in these trials to look at responders versus non-responders to see differences, to know what the therapy is actually doing, because obviously the good therapy is giving you more responders.
Yeah, and I guess in terms of what it means I was thinking about what that means in terms of the value of these therapies in the clinic. I guess if I start a patient on a biologic, whether it was Bulimumab or Anaphylaxis, as you showed me, or whether it's one of the standard of care therapies, if they don't respond in terms of disease activity, they don't really stay on it for very long, usually, because by 3 months, maybe 6 months at most. I've probably changed them and done something else. Whereas if they then do well on that, they could be on it for years. And that's what I want to know, isn't it? What does that mean in terms of quality of life? The person who's staying on that therapy and staying on it for years.
Yeah, I agree with you.
And
It's unfortunate because the SF-36 spidergrams were actually born to be reported by patients on their computer, and then they would get a spidergram back to show them how they were doing. And as it got better, the spiders would get bigger. And so many times after they started a new therapy, they would go into this program and check how much faster they were getting better, how often. So
yeah,
if we could make the SF-36 like that for patients, then they could use it, and then it would be helpful. It wouldn't be a burden on the practice.
yeah, yeah. And so would you agree with what the authors were saying about how maybe health-related quality of life should be targeted a bit more directly in these trials, sort of like it really is the outcome that's being looked for, and the strategies are particularly aiming at that, rather than just measuring it as a sort of secondary analysis once you've done the disease activity?
Well, I definitely agree with that. That's why I think we need new responder analyses, but that's going to take a bit of work and time. In the meantime, we can be, I think, confident that an SRI-4 or a BICLO responder means that patient is going to feel better.
Yeah, yeah. And it's just like the theme of the damage papers, isn't it? It's about, we initially look at changing disease activity, but then we try and see this network of other benefits coming out of that in terms of long-term damage, steroid use, quality of life, all these other things that need to be considered.
Yes.
Okay,
Thank you.
I think our next paper's, and it's another anaphylaxis one, actually. And this is actually, we've spent a lot of time in the previous podcasts looking at the randomized trials and the outcomes coming from those. But this is one of the first ones looking at a bit of real world data, which I think is something we all think about when a new therapy hits the market. So, okay, it's only a case series of 3 patients, but still, I found it quite interesting because what we saw in the TULIP studies was mainly benefits on the skin and the joint manifestations. We had BICLA data and SLEDAI data, which are global indices that you can break down into different organ systems. We also, I think it really came in with the anaphylaxis program. We also got CLASI data that gives you a bit more detailed and outcomes on the skin disease activity. But when you go to this real life case series, you learn a few new things that we still didn't know even from those. So here they've got 3 cases. They've all got resistant skin disease related to lupus. They failed many therapies, so they'd had other biologics and really quite a lot of other therapy. They got anaphylaxis. All 3 patients did really well. There are some photos in the paper that are quite impressive. But I think what you can sort of see here that maybe wasn't so clear in the TULIP trial results, when you just look at those bar charts, is you can see, firstly, the level of response seemed pretty high. Like these patients were all remission or close to it. They weren't just 50% change in CLASI. Some of these responses, and I've heard a few people mention this, and I've seen it a bit in my own experience too, they seem to occur pretty fast, actually.
Yeah.
So even 1 month, 2 months after starting therapy, you could see really quite big changes in disease activity. And another thing you see nicely here is that you start to get a bit more information on the different morphologies, because you've got, when we say cutaneous lupus, you can have acute cutaneous lupus, sort of the classic malar rashes. You can have a subacute picture. You can have these discoid lesions that can be quite nasty and scarring. And I'd previously seen in my own work that some of that discoid is much harder to treat with, say, like B-cell targeted therapies. But here they showed that doing really well.
Yeah.
So I think
these were really refractory patients, weren't they? I mean,
and that's the other thing. Yeah, that's right. And I that's another thing I've thought about with some of my own experience is that, again, if you think about rheumatoid arthritis, sort of the more biologics you've had, it always seems like the responses get less good. Your chance of responding gets less each time. But these are very, very resistant patients. They've had other biologics and they do really, really well. In fact, better than you might have expected from the trials. So I guess, okay, it's only 3 cases, but it just sort of show you that there's more to be learned when the drug starts going into real world practice and a more arranged scenarios, I think. And
also I think we don't pay as much attention to this type of refractory lupus. And so it's really good to see something positive, because it's been very hard to treat refractory CLE.
And actually thinking of the other, where we started, I actually think all of these patients were African American, weren't they? And they all had really good responses.
Yeah,
so that's a more positive response than the note we started on, I guess. Then you took a look at this one, didn't you? But this litifilimab study, although we actually covered this in another podcast recently.
Right. It's nice data. And we've been interested in seeing what's going to happen with this product going forward. So I'm a little surprised that we haven't heard more yet. But we've known about this work, and it's been nicely published now. So we have to be optimistic that we'll see more.
Yeah. So if for those who haven't seen our other podcast yet, there were two studies that both came out in the New England Journal of Medicine in the last few months at phase 2, looking at one focusing more on the skin responses, and one which is called the systemic lupus study, although it's actually mostly about the musculoskeletal disease.
Right. Mostly about the joints. Yes.
Yeah. So you sort of got a trial about skin, a trial about joints. And I did a podcast with Vicky Worth and Rich Fury, who are both members of the steering committee of the Lupus Forum, and they were the lead authors on those 2 papers respectively. So if you look out for that one on the forum, you can see a really detailed discussion where you get a discussion of the papers from the people who were really involved all the way through them. Okay, and this is our last paper we're discussing today, isn't it?
Yeah, I thought this was very brave.
Yeah, me too.
And I'm not sure that I'm ready to try this, but I do think that it's interesting. Again, it's 33 patients, but use of Bulimumab, which we have had now for almost 10 years, 11 years, we know is quite safe. I think it's still the question about whether you would add tacrolimus to it, but apparently in this particular series, it was actually quite effective and well tolerated. Only one patient developed a serious infection. And among other things, you could see that there was pretty effective glucocorticoid tapering over the period of time. So over about a year. And that, of course, does say a lot for it too. Now, this is just a single center. It is retrospective. And so we would need some more, shall we say, confirmatory data. But it certainly suggests that it's an option that can be tolerated and perhaps should be studied in more detail. I think, though, it also reflects the fact that our Asian colleagues are much more willing to use a calcineurin inhibitor than we seem to be in the West, in Western Europe and North America. And I don't know whether that has something to do with the differences in the patient populations, because we do know that they are different types of patients and do have differences in their lupus manifestations.
Yeah, I agree. I mean, I like you, I also thought that because Bulimumab and other biologics in trials, they are often given in combination with other oral immunosuppressants, but those are usually azathioprine, mycophenolate, and we don't have so much data on what happens with tacrolimus. Obviously, has a lot more sort of T cell effects. So whether you're getting a more comprehensive immunosuppression, so I did think it was a bit brave, but then again, I thought I was more interested having seen this. And of course, I think we're hearing more and more about calcineurin inhibitors, aren't we? So there was some, I think I think it was something, a substantial proportion of these had renal involvement, didn't they? Not all of them, but a substantial proportion. And that's been the main place where people have wanted to use calcineurin inhibitors. There have been some trials showing the benefits of tacrolimus. And of course, we've recently had the voclosporin data that also looked very positive. And I sort of thought, well, it kind of makes sense, because one of the things people say about calcineurin inhibitors in nephritis is this, as well as the immunosuppressive effect, they also have some direct benefits on the sort of the podocytopathy that you get, don't they? And that's why they might be particularly useful for certain types of nephritis and class 5 and things. So maybe it is quite a logical combination for those patients.
So I agree with you. And I think, the voclosporin data is a really good example of the fact that there is podocyte protective effects from calcineurin inhibitors. Yeah. Unfortunately, voclosporin is different. It's got a different predictable PK/PD. And so we can't really take the voclosporin data and apply it now to what we think might happen with tacrolimus. Yeah. But I do think the point is definitely there, that using a calcineurin inhibitor with something like Bulimumab actually should be a therapy that we try.
Yeah, and I guess as we get more and more therapies available to us, we start again to learn more from combinations, what's suited to different types of patients. And a lot of these data are coming from real world use. We can't do trials for everything. So I think that's all we've got time for today, isn't it? So thanks very much for joining me, Vibeke. It's always great talking through the literature with you.
I enjoyed it. Thank you.
And thank you to everyone for listening. All of the papers that we discussed today, they're available on the website as a full slide deck summary, so you can download the PowerPoint files for those. If you want to find out more, you can find them on lupus-forum.com. And you'll find other podcasts, including the discussions with the authors of the key papers, Congress highlights, and a CME accredited course, all available for free on the site. So do make sure you take a look. You can find us on Lupus Forum, or one word, on Twitter and on LinkedIn as well. So thanks again, and see you next time.